Hello, I'm Tom Davis, Director of Health Programs for Food for the Hungry. I'm sorry that I couldn't be with you there this week, but I wanted to talk to you about reducing malnutrition and child deaths using care groups, an approach that Food for the Hungry is used in quite a few countries now. And we want to tell you a little bit about some of the results we've seen, how care groups are set up, and why we recommend them for use in this project. Okay, let's start I wanted to give you a bit of an overview of what we'll be discussing. First, I'll give you a bit of background on two Mozambique projects that have used care groups, and then talk a little bit about some of the main challenges that we see in reducing child malnutrition and deaths, what care groups are and how we've used them, some of the results that we've seen using this model, and the results of other organizations in terms of preventing child deaths and malnutrition, and sustainability of the model. And then we'll talk about how we plan to use them in our Burundi Maya. Let me give you some information on the program background for this particular project. This project was done by Food for the Hungry. We're a nonprofit, faith-based PVO working in 26 of the poorest countries since 1971. We're currently managing Child Survival and Health Grants Program, Title II, USDA, PEPFAR, and a few other U.S. aid-funded type projects. This project was a USAID Title II project that went from 1998 to 2001 for the first DAP, and from 2002 to 2007 during the second DAP. The mortality study that we're going to be talking about examined communities involved in both DAPs from 1999 to 2000, going through to 2003-2004. The area where the project was conducted is in Nyamatanda, Maromeo, Gorongosa, and Kaya districts of Sofala province in Mozambique. And at this moment, we're scaling up to 10 districts in Sofala province through the USA Child Survival and Health Grants Program. The prime objective of the project was to decrease chronic malnutrition in children 6 to 59 months of age. And we had other behavioral objectives such as increasing exclusive breastfeeding, persistent breastfeeding of children 20 to 23 months of age, ORT, and feeding children during diarrhea, increasing DPT3, immunization, even though the immunization component wasn't a very big one. There were a lot of other behavioral objectives. We had a mortality decline in the project that we'll be talking about, but that wasn't the main objective. As far as interventions, they were child survival type interventions, very similar to what we're doing in our child survival program, focusing on nutrition, especially child nutrition, control of diarrheal disease, acute respiratory infection, malaria, safe motherhood, and HIV. So it's pretty broad-based. In the scale-up, we're focusing it down to work on nutrition and control of diarrheal diseases with integration through integrated management of childhood illness. But in this original project, we had quite a few interventions. This project has outpaced other Title II PVOs in Mozambique in terms of the reductions in child malnutrition and also the speed of behavioral change. And that's one reason we think it's interesting to look at this project so that we can take a look at what happened and why we believe it happened. Okay, this is a map of Mozambique. We've circled there Sofala province. You can see is near the center of the country. And we worked in several districts in this area that I've also mentioned, and we're now scaling up to 10 of the 12 districts there. This is a graph from the Lancet Child Survival series where they estimated under 5 deaths that could be prevented in the 42 countries that have 90% of world child deaths in 2000. And you can see from this table here, which is cumulative, that if you pull out those things that we can change at the household and community level, like breastfeeding, complementary feeding, water sanitation and hygiene, that a full 57% of all deaths could be averted by making changes in those things right at the household level. And that's one reason that we focus so much on making the change happen at the household level, is knowing that this is true. I believe the same thing is true of malnutrition, if not more so, that it's behaviors at the household level that are going to be able to turn around malnutrition. And one of the reasons that prevention gets such an important piece in the prevention of the PM2A approach that's now being promoted within Food for Peace. The challenge that we faced in designing this project was similar to the challenges that we face in a lot of child survival programs in Title II health and nutrition programs. And that is to decrease child deaths and malnutrition. we need to improve health behaviors through a structure that first facilitates behavior change. Behavior change in the household, we believe, is the key. Reaching large numbers of caregivers of young children on a regular basis with high-quality health promotion at low cost. It needs to assure equitable and universal coverage, not just for those who show up, realizing that a lot of the mothers who are able to show up to growth monitoring posts and other fixed meetings are sometimes the mothers who need what they're offering the least. It needs to allow for mothers to have a trusting relationship with the health promoter and to receive tailored messages. That sort of trusting relationship, we believe, is necessary in order to see a lot of behavior change happening. It needs to strengthen social support to decrease dropout of volunteers and also to assure continued health promotion after the project ends. That social support, that strong social support, also does a lot in terms of building women's empowerment. It needs to build capacity in the community and keep tasks for volunteers light to decrease dropout of those volunteers. It should use few paid staff if we want to have a low cost per beneficiary as well. We believe the care group does this. In some settings, there might be additional challenges, and we feel the care group might not be the best approach, but we feel like in a lot of settings, care groups are able to meet this challenge. Let me mention what the basic idea is of a care group. It's a community-based strategy for improving coverage and behavior change. It was developed by Dr. Peter Ernst with Rural Relief in Mozambique and used subsequently by Rural Relief in Cambodia, Malawi, and Food for the Hungry helped pioneer this method as well. We were one of the first organizations after Rural Relief to use it. We definitely owe a lot to Rural Relief for teaching us how to do this. And subsequently, a lot of different organizations, about 15, have begun using care groups. And it focuses on building teams of volunteer women who represent, serve, and do health promotion with blocks of about 10 to 15 households each. And we'll talk more about that, about the structure and what is done during care groups in a few minutes. There were several major program inputs in this project. In general, I think it is quite a simple project at its base, and yet has done some things right that has led to quite a bit of impact. We have one paid promoter who usually has 7th grade education or higher per 1,680 beneficiary households. That can vary a bit depending on your structure. One supervisor who's usually a nurse per 7 to 10 promoters. 4 to 5 day training on each of the 8 modules that we offered in this project. Sometimes there are fewer modules, sometimes more. And we have about 3 or 4 trainings per year for the first 2 years. You need educational materials, especially flip charts, for both the promoters and the leader mothers. You need bicycles or some form of transportation for your promoters usually. Sometimes we've used half-time promoters who cover a smaller area and been able to decrease the need for transportation. Vitamin A, deworming meds, and other supplies are often used with this model as well. There's one child survival program manager involved at the field. 1/3 of a full-time equivalent of M&E staff, so some involvement of M&E staff. 0.65 full-time equivalents of a headquarter backstop in this current project that we're doing in child survival. That can vary a bit too, but we feel like it needs a bit more help than some of our other projects in getting this set up. But in general, not very heavy staffing, I don't feel. The MOH involvement is helpful, but does not require a high level of integration. Now, in some of our more recent care group projects, we're also using community development committees. These are formed in each area with a care group, and their leaders are trained by FH project staff. And their roles are taking responsibility and ownership in planning and implementing community development activities, especially those geared around health, encouraging and supporting existing community groups like the care groups, agricultural groups, other groups that may exist, and doing advocacy for community needs to a wider community district governance structures, so there's an advocacy role for them as well. They're given a small fund, about $500 usually, to manage for health-related projects to support health promotion in care groups or other projects that they want to take on. It's important for them to have some funds so that they once they come up with plans, there's actually something they can move forward with. They can work with their local resources as well, but it's helpful to have some external funding coming into these groups. And it does require additional staffing than what I've presented for the care group structure. Usually the promoters are not the best ones to be training these groups. Often they're already working full-time and meeting with the care groups, so it's important to think about staffing for the people that need to go around and train these groups. Okay, this is a diagram showing the structure of the care group model. First you do a census. You have groups of 10 to 14 households that are established with women with children 0 to 59 months of age, or in this case it was children 0 to 23, through an initial census. And then one leader mother is elected to represent each of these household groupings of 10 to 14 households. 10 to 12 leader mothers then come in to meet in a care group, and they receive 52 hours of training each year, about 2 hours of training every 2 weeks. Beneficiary mothers receive about 13 or more hours of training every year, and I think that's one of the reasons it's successful, is the high amount of content and relationship building that happens between the two. Each paid promoter meets with about 10 care groups every 2 weeks, and the turnover of these care group leader mothers has generally been quite low. Most of the training of the care group members can be done at the community level, and that helps to keep costs low. Now this is what our structure looks like for the care groups in Burundi, where we have a My up there as a sub to CRS. Food for the Hungry basically as a behavioral change communication technical advisor in Burundi, and also under that person in each of the provinces there are 2 BCC coordinators. And each of those BCC coordinators works with a group of promoters and supervises them, helps to train them. Those promoters, and in turn, you see this one promoter circled in green, will work with 7, 8, 9, 10, 11. I was trying to look, 11 groups of 12. That structure, of course, can depend on the topography and that sort of thing. And then each of those groups, those care groups where the mother leaders come together, they then go out and reach mother beneficiaries, MBs shown on this. So it's basically the same sort of structure in Burundi. It just shows that top level we have BCC coordinators, and FH is responsible for one IR, which is the behavior change communication at the community level, that IR. Okay, so what happens during the care group meetings? One thing is reporting of vital events and illnesses and the progress in health promotion by the leader mothers. They do some troubleshooting. Also there's a demonstration with a flip chart or a poster of this week's 2 to 3 health messages. There's a group reflection on the messages, and then the leader mothers practice with the flip chart in pairs. And there are other social activities like songs, dramas, and games. These small, frequent meetings with these leader mothers is probably one reason for their success. There's a lot of empowerment of women and ownership that comes through this group structure. Okay, so what happens after the care group meetings? Well, each leader mother visits her 10 households in the following 2 weeks. That's an individual home visit that she makes for those households. Each leader mother educates her mothers on the key health and nutrition messages for the week using a small black and white flip chart. The promoter supervises the health promotion done by the leader mothers, not by all of them, but picking a particular one that will be supervised each time that the promoter goes out. There's deworming and vitamin A given during campaigns every 6 months, and that's coordinated with the MOH. Also, immunizations are offered sometime where the MOH can bring that in. And very little health facility improvement, though, was done as part of this project. Really, the focus was on community-level health promotion, and we can see how that changed mortality. Another reason for the success of this model is probably the frequent home visits from a neighbor who's not very far from the person culturally, educationally, or geographically. I think having that narrow distance between the person doing the health promotion and the mother really helps. Now, of course, you can't just send out your promoters and leader mothers after giving them some training and expect everything to go well. We do believe that it's very important to monitor the quality of the work being done. One tool we use for that are quality improvement and verification checklists. These are basically 2-page long, fairly detailed checklists on what someone should be doing for a key process. For example, this yellow line here is for community integrated management of childhood illness. There's a process for that. Some of our leader mothers, usually about 1 per group, is trained in CIMCI, and they do consults with mothers that have sick children. So we'll monitor how they're doing that, just sitting, observing them, checking off the list, and then the the promoter, for example, will give feedback in a private place to that CIMCI trade leader mother. You can see at the beginning of this process, this is from this year, October of last year, it was only at about 55%. We had them trained. The Minister of Health did that training. Training was really not the best. It was a bit too high of a level. We've revised the training manual since then that was being used with them. But by using this checklist, we were able to then go out, observe them doing it, giving them feedback, very supportive feedback, explaining not only what they did wrong, but what they were doing right. And you can see over the course of a year, we got those scores over 80%. And that's the most complicated process we have. There's also a checklist on providing education to individuals, like when a leader mother is giving an individual talk in the home and going through her flip chart. That shows the quality of that. Another one when they're doing health promotion in the care group itself, when the promoter is doing it. That's the dark blue line. And then another one for the supervision that's being offered to that promoter. So those are just some of the different key processes that we monitor and use that checklist to try to improve that quality over time. Now, there are some differences in how we've applied care groups in Burundi where we're using the PM2A approach. One is during any given month, the leader mother does one home visit to each beneficiary mother and child, plus one group meeting with all beneficiary mothers. So basically they take turns. 1 2-week period, they do home visits to every mother. Another 2-week period, they bring all the mothers together to educate them in that group, all of the beneficiary mothers under that leader mother. So every leader mother has a small group meeting with her beneficiary mothers. Now, there are benefits of both. Getting inside that household can be really important in terms of knowing what the mother has to work with, what her home life is like, what are the barriers that she has there. You can observe whether she's actually using some of the things that you've been promoting, like having a hand washing station. That can really help. So we want them to get in the households. But there's also some dynamics that can happen in a group and some things you can do in a group that help as well. So we encourage both. We would say never give up the individual home visits. We don't think care groups would work if you only did group meetings of mothers. But we're fine with having some of those meetings, about half, be in a group setting, and then the other half be in that home visit as well. Another thing that helps with is that problem of equity. If you just have group meetings, only the mothers who were able to make the time and don't have controlling husbands, for example, will be able to show up to that meeting once a month. But by going to the home, you make it easier for those mothers who find it harder to get away or maybe just have a little bit less motivation to come to a group meeting. Another thing is during the home visit, in addition to sharing the regular module message, they share 2 to 3 age-specific messages. So they are on a schedule of giving out messages, things that they just learned in the past 2 weeks, and then they go out and teach their beneficiary mothers what they learned from the promoter. It's necessary to do it that way. You can't have everyone learn everything at once. So you have to kind of roll out messages. But in order to begin from the very beginning, giving some age-specific messages, we are also going to teach them how to use a card with the most important messages to use for each age group. And when they're doing the health promotion on that, they won't be able to give as much of the why and how to overcome barriers, but they will at least be able to tell a mother, for example, why that she should be exclusively breastfeeding, what that means, and maybe a little bit of the why. And then later on, when she reaches that particular lesson plan, she can go into more details. And also in Burundi, a health system strengthening piece is included. We have a health system strengthening IR that's part of that My App. We're not as involved with that one. We'd be more than happy to be very involved with it in other countries where we apply this model. And with that, you're basically going into the health facility, helping them to strengthen the health promotion that's done by health workers, helping them to strengthen, for example, integrated management of childhood illnesses to assure that when kids come in who are sick, that they're doing the right things. And also for pregnant women are reached there with improving the antenatal care that's being done for pregnant women coming into the health facility as well. And I should mention, we've seen really nice changes in terms of health service utilization by just using care groups at the community level without changing anything in the health facility. We've still been able to really increase the usage of health facilities in the areas where we use care groups. And I'll show you some graphs on that a bit later. Okay, you now have a lot of the background on this care group model. Let's look now in terms of results and impact. How effective are care groups in reducing child morbidity and mortality? I'm not going to give a lot of background in terms of the study methods used in this, so we really just don't have time, but I will give you an overview of what was done. There was a baseline mini-KP and final KPC surveys that were done to look at behavior changes, and also a mortality study that was done through Johns Hopkins using a modified DHS approach. A pregnancy history questionnaire was used and modified from that, from the 2003 Mozambique DHS birth history questionnaire, and that was the main tool used to look at deaths that had occurred. We also used anthropometry to look at how malnutrition had changed. When we look at the results from the KPC survey and anthropometry, in general, we see large and rapid changes in key child survival behaviors. Here are just a few of the changes that we saw. The percentage of children with diarrhea receiving appropriate oral rehydration liquids went up from 26% in fiscal year 97 at baseline to 95% at the year 2000 follow-up survey. Percentage of children 0 to 4 months who were exclusively breastfeeding, that was an indicator that they were using a Mozambique at that time, went from 46% at baseline to 83% during the follow-up survey. Children 12 to 23 months who received a vitamin A capsule in the last 6 months went from virtually non-existent to 97% during the 3 years there. Percentage of children with diarrhea in the last 2 weeks went up from decreased from 44% down to 28%. And we looked at that each year, and so we did see a downward trend. We don't give as much attention to that since diarrhea can really fluctuate during a year, but it appears that that went down. Severe stunning, this was a very important finding, decreased. For children 6 to 23 months of age, it went from 25% at baseline down to almost half, 13%, during that follow-up survey. And moderate and severe malnutrition also decreased. This graph shows what sort of change we saw in Mozambique and our percentage of children with diarrhea who were receiving appropriate oral rehydration liquids. Once again, a very rapid increase in the first 2 years and then leveling off. By the way, that pink bar shows what we found in our final KPC, which was done with a little bit different methodology than the yearly tracking, but confirms that we were basically right at our target by the end of the project as well. These indicators were tracked on a yearly basis, and this shows the progress that we saw in exclusive breastfeeding. And one thing I'd point out that for a lot of these, we saw most of the change happen during the first year or the first 2 years when we put the process in place. So we've seen some really rapid change. Here's percentage of children 12 to 23 months who had received vitamin A in the last 6 months. We didn't work on that in the first year of the project, and then we started working with the Ministry of Health and also doing community level distribution of vitamin A. So that's one thing we worked out, where we could actually use the care group structure to begin distributing vitamin A. And you can see that we basically met our target within 1 year with that one. We talked about this earlier on the table, the decrease in diarrhea during the last 2 weeks. Diarrheal prevalence we found in a number of our local determinants of malnutrition studies is just strongly associated with malnutrition. We know that malnourished kids get diarrhea more often, but it's even as stronger in the other direction of children who have frequent diarrhea are much more likely to become malnourished. And here is one of our most important findings in this project, the decrease in severe stunning of children 6 to 23 months of age. We almost cut that in half. Those boxes basically show the confidence intervals around those two numbers, so 25% in baseline with a confidence interval of 20.3 to 30.8, and then a decrease down to 13% at final. And you can see those boxes don't overlap. It was a statistically significant change there. So in our completed Title II project that used care groups in Mozambique, we saw that 48% reduction in severe stunting, 25% reduction in moderate and severe stunting. In our current child survival project using care groups in Mozambique, we've changed what we do a bit. Instead of reaching all households under 5, we're concentrating on all households of under 2 and pregnant women, the same as the PM2A approach in that sense. And we've seen really nice changes in malnutrition there as well. A 42% decrease in underweight between February 2006 and September 2008. And you can see by this graph that it was really long before that 2.5 years, and only about a year's time, we actually saw a very nice decrease in malnutrition in the project in Mozambique that we're doing currently. That last set of results was from our Title II care group project that we did in Mozambique and completed. This one is on our current FH Mozambique Child Survival, just to give you an idea of some of the results there. For example, exclusive breastfeeding has gone from 17 to 77%. This from baseline to midterm. So only after 2.5 years, we've seen almost a 3.5-fold increase with that. Children who receive foods other than breast milk at least 3 times per day went from 33 to 58%, so a 76% increase. Children 6 to 23 months who consumed at least one vitamin A-rich food also increased from 29% to 81%, so 180% increase. The percentage of mothers of children 6 to 23 months who know at least 3 child danger signs went from 29% to 93%. So keep in mind for some of these, think about the vitamin A-rich foods and feeding a child at least 3 times per day. There was no agricultural component for this child survival project. There were no rations as well. It was purely doing promotion of these behaviors. We'll talk later about some of the tools we use to improve the messaging that we use and some of the activities, something we call barrier analysis and also local determinants of malnutrition studies. But we feel that when you do this community-based social marketing and do it well and do the studies you need to do to find out what your messages need to be, you can see large increases in these behaviors even without additional inputs going in. This is an example of health service utilization and how that changed in this project that used care groups. This is just an example from one district in Mozambique, Kaya district, and the data is from 2009. We have a child survival project right there using care groups at the moment. Notice child weighings increased 67%, initial prenatal consults increased 44%, subsequent prenatal consults went up 86%. Health facility births, they saw a 95% increase, almost doubling. Children 0 to 11 months who went in for consults, they saw a modest increase of 32% with that. And if you just looked at what would be an expected increase on these numbers based on population growth, you'd only expect about a 4% increase. So we believe these are related to the presence of care groups and really motivating women to use the services that are available. I'll show you next a little bit of data showing the comparisons between areas that had care groups and that didn't. So you may be thinking, well, maybe in Kaya, the Minister of Health was doing something different. Maybe that's the reason for the increase. So we decided to explore that in our midterm evaluation by comparing 3 districts where we're using care groups in Mozambique, Kaya, Chimba, and Maringwe districts, and compared that to 3 other districts where we were not using care groups in Mozambique, in Buzi, Chibababa, and Dondo in the same province. And this shows basically the data for each one. The blue lines are the care group areas, and the pink lines are areas where they were not using care groups, where the Minister of Health was active but not using care groups. And you see that in each one, weighings per child, it goes up pretty dramatically in areas with care groups, and the areas where they're not using care groups, it actually fell a bit. Institutional delivery is fairly flat. Up in the care group areas increased pretty dramatically. And the interesting thing too is we didn't even have a maternal and newborn component of this project. It's partly just, I think, rallying the mothers, getting them more interested in using health services, explaining some benefits in general. And once they start using it for one service, they're more likely to come in for another service. Initial prenatal consults, same, about flat in the 3 areas, the pink areas, Busi, Chibababa, and Dondo, and in the areas where these care groups went up. And infant health facilities went up as well compared to a decrease in the other areas in these districts in Mozambique. Now we look at the impact of the project. What we've compared on this slide is the changes in mortality in the project area between March 99 in February 2000 and March 2003, February 2004, those two periods, compared with the DHS data for that 6-year period shown. We saw a decrease in under 5 mortality rate in the project area of 62%. In terms of the DHS, only a 15.3% decrease. The infant mortality rate went down 42% in the project area compared with a 14% decrease in the DHS for the Sofala province in general. And the child mortality rate, the most dramatic reduction, we saw a 94% decrease in the child mortality rate in the project area where we're using these care groups compared with a 21% change regionally. So when we compare this to the regional changes, we see that the under 5 mortality rate for the project area decreased 3 times as much, the IMR decreased twice as much, and the child mortality rate decreased almost 4 times as much as the regional rate. I have quite a few graphs on this as well. This is just to show how the child mortality rate just stair-stepped down from 41 per thousand to 3 per thousand during the life of this project, so a 94% decrease in the child mortality rate. What about cost per beneficiary for this program? The cost per beneficiary per year was $4.50 in this care group project. That's USAID costs. And FH has made additional changes to the model in its expanded impact child survival project, dropping the cost per beneficiary to only $3.21 per beneficiary per year. There is other evidence of success in terms of reducing mortality with this care group model. Rural Relief found a 49% reduction in the IMR and 42% reduction in the under 5 mortality rate in their care group project in Mozambique between March 2000 and February 2003. That was in Gaza province. Their cost per beneficiary was $6.50 when looking at direct beneficiaries. This is just a copy of their paper that they have submitted for publication with the Royal Society of Tropical Medicine and Hygiene. Food for the Hungry is now working on having our data published as well. Now, Food for the Hungry has probably the best cost per life saved. When we've plugged in our numbers into something called the Bellagio Life Saved Calculator, we saw that our cost per life saved was only $305. That's way below what a lot of other published studies shows for the cost per life saved using a lot of different approaches. It's often closer to $2,000 or $3,000. We've done some analysis looking at different organizations using care groups and to see what they're finding, if this is being found in other settings. For example, in Plan in Kenya, in Rwanda, Rural Relief used the model, and also in Malawi. And when we analyzed these 17 projects, we saw that given an average decrease in under 5 mortality of about 18% in a 4 or 5 year project, all of these projects except for one, which were care group projects, all of them had a higher reduction in the under 5 mortality rate except for one of them. So 6 out of the 7 projects showed higher than average reductions in under 5 mortality. And we think we'll see as well higher reductions in underweight and in malnutrition. That data we don't have at our fingertips as easily, but we want to start looking at that as well as how does this perform compared to other projects when we look at it across a lot of different organizations. We know that with Food for the Hungry, we've seen very dramatic decreases in malnutrition, and we expect that to be so compared to when we look at other organizations as well. Okay, one question you should be asking yourself at this point, after seeing these nice reductions in malnutrition and under 5 mortality, nice increases in behavior change and rapid increases, is will any of this stuff last? If you put this into place, does it last? That's one of the things that I've been most impressed with about this model is the sustainability of it. It's a different idea of sustainability. Sometimes we think of sustainability as is the Ministry of Health going to pick this up and continue going out and using this and to me, I've had to change my thinking a bit on that because where the sustainability happens is right at the community level. These are basically community clubs that can be formed and that can continue to exist and to run if they're set up properly. This graph, Rural Relief has done some studies. Food for the Hungry has not gone back to study in areas where we've done care groups, but World Relief did this with their care group projects in Mozambique. This graph shows the beginning of the project, September 95 on the left. That purple bar that you'll see on these is end of project. So World Relief left the area, and then there's another dot at 20 months after the end of the project, and then another dot at 30 months. Those are the two times where they went back and measured their results to see what was happening on a lot of key indicators. For example, children with diarrhea treated with ORS, that black line, by the way, is their goal. It was to go up from about 48% to 60%. They surpassed that during the project and went up to about 80%. When they went back 20 months later, it was still up over 80%. When they went back 30 months later, it was actually right at 100%. Every mother that they asked in their sample said if their child had diarrhea, they had to use oral rehydration serum. We'll explain why that's happening in a minute. So they found that 93% of their leader mothers were still active 20 months after the project ended, and half of the women in the communities have received a visit from their leader mother in the past 2 weeks. So the frequency of visitation probably wasn't as often as when the project was occurring, but these leader mothers were still out there. They still had their flip charts. They're still going out and visiting mothers, and about half of them said that they had received a visit in the past 2 weeks from a leader mother to come do health promotion with them. So I think that shows a real high level of sustainability is possible. Also, they measured at 2.5 and 4 years post-project, as I mentioned, and those results were sustained or improved. So what happened for those 7% of leader mothers who had either dropped out or moved or died? Communities on their own replaced 40 of the 132 vacant volunteer positions. The leader mothers who had left or died were replaced, 40 of the 132 of them at least. And the remaining leader mothers trained these new leader mothers and gave them educational materials to use. So that's the mechanism that the local communities were using to teach these new leader mothers. They didn't have to have the Ministry of Health to come out. They had enough seasoned leader mothers that they could pass along this skill to the new ones. Now, of course, it is helpful if the Ministry of Health can engage to continue working with these groups. And we are still working, doing advocacy around that to try to get Mozambique to adopt this model on a national. Okay, that was for a household level behavior. What about something that requires the integration and coordination with the Ministry of Health, something like children who are completely vaccinated? World Relief also looked at that. They had brought up percentage of children completely vaccinated to over 90% by the end of the project in September of '99. When they went back at 2.5 years after the end of the project and 4 years post-project, they had maintained those levels at over 90% in the communities that they had served. I want to thank you for your listening to this presentation.